Good day, and welcome to Achieving Health Equity. We're going over a few concepts about health equity and how they're applied to hepatitis elimination. In 2016, when the World Health Organization issued the recommendations calling for the elimination of hepatitis B and hepatitis C, we joined a very select part of public health that has been directed toward disease elimination and eradication. And you realize when you look at the history of disease elimination and eradication, that the guiding principle is health equity. The concept that you're going to apply a variety of public health measures and interventions to a large population, preferably a country and then progressively the world, so that everyone in that country benefits from that intervention. Now you're seeking to do that through direct interventions applicable to that disease and then general health system strengthening that comes from that. And then with these targets that are helping you create a sense of urgency, bring important partners to the table, and have accountability as you measure your progress toward these time-limited goals. But with all of that process is to achieve health equity. For us in hepatitis elimination, our goals are 90% reduction in incidence and 65% reduction in mortality by 2030 for hepatitis B and hepatitis C. So those are our global targets. But we recognize that hepatitis is not uniformly distributed around the world. We have about 257 million people living with hepatitis B, with the highest prevalence in countries of Asia and in Africa, and hepatitis C, about 71 million people. And then you have, again, differences geographically. So that's one health equity that has to be recognized, geographic differences. Then as we begin to think about the interventions that can be applied to achieve our elimination goals, we again have to think, how can we apply them to achieve health equity? The cornerstone of hepatitis B elimination is hepatitis B vaccination of infants beginning at birth, preferably within 24 hours after delivery. When that vaccine is applied, we see large reductions in prevalence among vaccinated cohorts, such as has been achieved in China, as shown in this slide, with some work still to be done in countries such as in sub-Saharan Africa. So in the case of this health disparity, there's a decision made that every infant should receive hepatitis B vaccine, even though that the infants at highest risk are those born to infected mothers. But because of the safety and effectiveness of that intervention, at the time of birth, and then completing that series later in infancy, it's recognized that you can achieve much more effective prevention than through some other targeted means. So hepatitis B vaccination is actually an excellent example of a general or broad application of intervention to eliminate a health disparity and achieve health equity. Another issue related to health equity for hepatitis B is the migration of persons who were infected with hepatitis B in early life in countries that had not yet implemented hepatitis B vaccine, and then moving to a country that had a lower hepatitis B. An excellent example of achieving health equity within a country for hepatitis B vaccine comes from China, where it was recognized that hepatitis B birth dose delivery was a particular challenge for children born at home, and they could not be reached in a timely way to deliver that vaccine when it could be most effective. So a decision was made to increase the facilities particularly in rural areas, so that children could be born in that facility rather than being born at home. That move probably had improvements in multiple aspects of maternal and child health, but it did create the environment where timely birth dose of hepatitis B vaccine could be delivered, resulting in a large increase in birth dose coverage for hepatitis B vaccine in China, helping that country achieve the regional goal of less than 1% prevalence among children vaccinated for hepatitis B. So again, a broad adoption of an intervention to remove a health disparity and achieve health equity. Another example of a health disparity for hepatitis B is the movement of persons infected with hepatitis B in early life from countries where hepatitis B vaccine was not yet put in place to other countries where hepatitis B prevalence is lower. I provide an example of countries in the European Union where they recognize that a sizable proportion of persons living with chronic hepatitis B were migrants from highly endemic countries. So it provides the information to direct hepatitis testing and linkage to care for those migrant populations. Of course, that needs to be done in a social, culturally appropriate way that can be well received by those migrant populations and be done in a way that's not stigmatizing so that they are reluctant to accept those services when they're offered. But it's important to have that information to begin with so that you can act on that information to benefit those populations. There are also differences in the prevalence for hepatitis C. Indeed, about 20 countries account for over 3/4 of HCV-related deaths. So again, at the global level, it's important to prioritize resources and technical assistance to those countries that have the highest prevalence of hepatitis C or the largest number of people living with HCV infection. Transmission in healthcare settings through unsafe injections still accounts for a sizable proportion of all infections with HCV. So it's very important to improve infection control for healthcare delivery. Now, when you look at it globally, there's been about over a 90% reduction in HCV transmission because of improvements in injection safety related to healthcare. So those countries are seeing declines in HCV infection as a result. Some countries are still challenged. I'm providing an example of Pakistan, where infection control still needs to be improved in healthcare settings. So that disparity still persists, but through sharing lessons learned from those countries that have been successful in this area, can assist Pakistan improve this aspect of HCV prevention. You can also begin to direct services to large segments of the population. In the case of the United States, it was recognized that persons born between 1945 and 1965 had an increased prevalence of hepatitis C because of exposures prior to viral discovery in 1989. So we recommended that all of these persons be tested for hepatitis C in 2012. And then over time, the number of persons born in these years increased, particularly so in just the most recent years, contributing to a decline in hepatitis C mortality as those persons that were diagnosed were being treated, cured, and having a much less risk of liver-related complications from their cured HCV infection. So again, this is an example of how you can target a large segment of the population to reduce their disparity of risk for HCV-related mortality. You can also target a facility. It's well known that the incarcerated populations have an increased risk of HCV infection. That's true in almost every country around the world. They're often marginalized because of their incarcerated state. They're really at the disposal of the government of whether that testing and treatment services are delivered to them. So this population definitely is a high priority based on prevalence, and because they're marginalized and unable to receive these services on their own action. Then lastly, you can target populations based on a risk for transmission. And of course, for HCV, the greatest risk for transmission is among people who inject drugs. As a result, the incidence is quite high in that population. The prevalence is quite high in that population. They need prevention services to provide safe injections and access to drug treatment programs, as well as the HCV testing and treatment. So this is a major area. Again, these populations can be marginalized, can be stigmatized, so they need extra attention so that they do benefit from an HCV elimination program in the country at large. So health equity is front and center of everything that should be going on around hepatitis elimination. And that has to carry through to the very end of the program when you're beginning to document progress and document achievement of goals. We are currently working with the World Health Organization as they begin to identify, we're beginning to work with the World Health Organization as they begin to develop guidance regarding how to document achievement of these global goals for hepatitis B and hepatitis C. And it's important to look at how health equity is handled in other disease elimination efforts. Now, the Western Pacific region has already, for many years, has had a hepatitis B control program with time-limited goals, with a verification process in place. And in that region, there's an advisory committee that documents the achievement of reductions in prevalence, but with particular attention being paid to the populations where there may be the greatest likelihood of hepatitis B vaccine not being effectively delivered and an ongoing risk for transmission underway. So recognizing those subpopulations at highest risk. Similarly, for HIV and syphilis elimination, there's a recognition to specifically address lowest performing administrative units where the prevention efforts may be the most fragile and the most limited, so that you're looking at the weakest part of the system rather than a focus on the strongest. And then lastly, just again, looking at the approach for malaria elimination, how again, they're calling out those populations at highest risk for transmission of malaria, and perhaps those that again have the poorest access to preventive services. So in conclusion, health equity is the guiding principle for disease elimination. The achievement of health equity can be addressed in a variety of different ways through the delivery of broadly of an intervention throughout a population, or by targeting subpopulations or particular settings or populations at risk. At the end of the day, we want to achieve our elimination goals in a way that every person in that population benefits. Thank you.